Hello everyone, welcome. I'm Dr. Shariful Halim and today I'm going to talk about adrenal insufficiency and the basics of hyperaldosteronism. So let's just first talk a bit about the function of aldosterone and how it is controlled. So aldosterone is a hormone that is secreted from the zona glomerulosa of the adrenal cortex, and its basic action is on the kidney. It causes increased sodium reabsorption, increased potassium secretion, and increased hydrogen secretion. So the basic or net effect will be increased sodium in the body or hypernatremia, which will also lead to increased water reabsorption, ultimately hypervolemia and hypertension, increased potassium secretion leading to hypokalemia, and increased hydrogen secretion leading to metabolic alkalosis. So those are the basic net effects of aldosterone. And aldosterone secretion is actually controlled mainly by the renin-angiotensin system. So whenever you have a decrease in blood volume or decreased blood pressure, your macula densa will be activated, and they will actually activate the JG cell or juxtaglomerular apparatus to release renin, and this renin will activate the angiotensinogen to angiotensin, and after action of angiotensin converting enzyme, this angiotensin will become angiotensin 2, which is here written here, and angiotensin 2 has the receptors on the aldosterone releasing cells on the glomerulosa, and they will be activated by the increased amount of angiotensin 2 and increased secretion of aldosterone blocker. And also, whenever you have a high plasma potassium or hyperkalemia, it will also stimulate the release of aldosterone, or also known as mineralocorticoid, from your zona glomerulosa of the cortex of adrenal gland. So those are the basics of aldosterone. So here we first start with the adrenal insufficiency. So whenever someone has adrenal insufficiency, commonly they mainly have the deficiency of mineralocorticoids, and also they might have a deficiency of glucocorticoids. But the features of deficiency of mineralocorticoids are predominant. So this is the dominant hormone here. So the deficiency features will be mainly due to mineralocorticoid deficiency. But some features are also due to deficiency of glucocorticoids. So the symptoms of adrenal insufficiency are included are weakness. Weakness most commonly occurs due to deficiency of mineralocorticoid. If someone has a deficiency of mineralocorticoid or aldosterone, he or she will lose a lot of sodium through his urine. So there will be hyponatremia and also loss of volume, so hypovolemia, so hypotension. So this hypotension might render a patient weak and fatigued, and the patient might have orthostatic hypotension. And also volume loss and deficiency of glucocorticoids might lead to loss of weight. So as you can remember that whenever someone has Cushing syndrome or an excess of glucocorticoids, they have deposition of fat in different parts of the body. And whenever someone has deficiency of glucocorticoids, they will actually have a loss of weight, so weight loss due to actually lipolysis. And one important feature is sugar or salt cravings. So glucocorticoids major function is one of the major function in sugar metabolism is it increases the blood sugar level, especially in stress situations or especially during periods of starvation. So during periods of starvation, glucocorticoids actually increase the synthesis of the enzymes responsible for gluconeogenesis in the liver. So when you don't have the enough glucocorticoids, now you cannot synthesize enough amount of sugar, so this might render the patient hypoglycemic, so the patient might develop sugar cravings. And also the patient might develop salt cravings, because as you do not have enough aldosterone or mineralocorticoid and you lose a lot of sodium through your urine, so that you have lost a lot of salt, leading to salt cravings. So those might present under the classic. So diagnosis of aldosterone insufficiency is made commonly by measuring the serum electrolytes, serum cortisol, ACTH, and also acetate stimulation test. Another test or other type of test is Mineralocorticoid stimulation test. So Mineralocorticoid is a substance which actually blocks the ultimate step of cortisol synthesis, which is a conversion of deoxycortisol to cortisol. So if someone has a normal response to Mineralocorticoid stimulation, that will be like Mineralocorticoid will actually decrease cortisol, and there will be compensatory increase in ACTH. So this is normal. But in case of adrenal insufficiency, you already have a decreased level of cortisol. You already have a damaged pathway. So you already have a pathway which is practically inhibited. So you cannot actually inhibit the inhibited pathway. So that's why the Mineralocorticoid actually cannot inhibit or cannot decrease the level of cortisol further, because it is already decreased, and that's why there is actually no change in the cortisol level after giving Mineralocorticoid. So in case of adrenal insufficiency, the ACTH remain decreased after the test, because you cannot actually decrease the cortisol further because it is already decreased. That's why ACTH remains decreased or low. So here comes the primary adrenal insufficiency. This occurs due to loss of gland function. So you have a deficiency of aldosterone and cortisol, both of them. And the most important features are already mentioned in the basic part. Is there will be hypotension because of loss of sodium, and volume contraction due to loss of water along with the sodium, and importantly hyperkalemia, because as you might remember, aldosterone is responsible for secretion of potassium from the distal tubule. So as you cannot lose potassium, you will have enough excess potassium in your blood, leading to hyperkalemia. And you cannot also excrete hydrogen ions, so it will lead to a buildup of hydrogen in your body, or acidosis, metabolic acidosis. And one very important and striking feature is skin and mucosal hyperpigmentation. So this is a bit different. It is a different mechanism. So remember that if you have a decreased amount of cortisol, this decreased amount of cortisol will actually have an impact on the first on the hypothalamus and then on the anterobutary. So your body will try to increase the synthesis of CRH and also ACTH in response of a decreased cortisol. So there will be increased ACTH production. But as you can remember, CRH stimulates the production of the preliminary product of ACTH, which is pro-opiomelanocortin, and this pro-opiomelanocortin actually ultimately gives rise to not only ACTH but also MSH. So the corticotropin releasing hormone stimulates the synthesis of both ACTH and MSH, and as the synthesis of pro-opiomelanocortin is increased, there will be increased synthesis of both ACTH and MSH. And MSH, or melanocyte stimulating hormone, is a hormone which stimulates your melanocytes to produce melanin. So there will be excess production of melanin pigments, and there will be hyperpigmentation, especially in your regions where you had some trauma before, like scars for trauma or scars from surgery, or pressure regions or knuckles. So those are the common areas, and also you can have hyperpigmentation in the pharynx or mucosas. So primary adrenal insufficiency, depending on time, it can be acute or it can be chronic. So acute adrenal insufficiency occurs due to massive hemorrhage commonly, and one common example is Waterhouse-Friderichsen syndrome, seen in meningococcal septicemia, and this might present with shock in acute adrenal crisis. This occurs due to deficiency of aldosterone mainly. And chronic adrenal insufficiency is also known as Addison's disease, and the most common causes are adrenal atrophy due to any reasons like autoimmune disease, TB, metastasis. So autoimmune disease is the most common. So primary adrenal insufficiency, the most important feature to remember that primary pigments the skin or mucosa. Very important to remember, very important. Okay, so the most common cause is autoimmunity, and the autoimmunity is commonly associated with autoimmune polyglandular syndromes. And one of the acute cause of primary adrenal insufficiency is Waterhouse-Friderichsen syndrome, where there is adrenal hemorrhage associated with septicemia due to meningococcal septicemia, and the patient presents with DIC and endotoxic shock and features of adrenal insufficiency. So secondary adrenal insufficiency occurs due to a problem commonly with your anterior pituitary. So in case of primary adrenal insufficiency, your adrenal gland is damaged. In case of secondary adrenal insufficiency, you have a normal adrenal gland, but now you have a problem with the anterior pituitary. So there will be a diminished pituitary ACTH production, and that's why one very striking difference between primary and secondary is there is no skin or mucosal hyperpigmentation and no hyperkalemia, because aldosterone synthesis is preserved. As you might remember from your previous knowledge, that aldosterone synthesis is actually under the control of renin-angiotensin aldosterone system. So as you have a deficiency of ACTH, it will mainly affect the secretion of cortisol, and it will not have any effect on synthesis of aldosterone. That's why the patient will not have any hyperkalemia, and there will be no hyperpigmentation, because you only have an increased synthesis of ACTH, maybe ACTH secreting adenoma from the pituitary gland, but you are not having an increase in MSH. So that's why if MSH is not increased, you will not have any hyperpigmentation. So you can remember by that, secondary spares the skin and electrolytes like potassium. The last one is tertiary adrenal insufficiency, which is actually not so uncommon, very common. It is seen in patients with chronic exogenous steroid use, and whenever someone uses steroid for a long time, his pituitary and hypothalamic axis is actually inhibited. So long-term steroid use will result in low level of CRH and low level of ACTH, and low level of ACTH will actually cause the adrenal gland to atrophy. So the patient is actually only dependent on the exogenous source. So whenever this patient needs an increased amount of steroid for some reason, like she or he is going on a surgery or going to have a surgery, or has a trauma, now he or she didn't increase the dose, but he needs more steroid. As his or her glands are not functioning, are atrophied, he or she cannot meet the demand. So now they develop an adrenal crisis. Very important. This can be precipitated by abrupt withdrawal or an increased demand. So aldosterone synthesis is unaffected in these patients, and you can remember tertiary from treatment of the patient with steroid. So there are some other disorders which are due to excess of aldosterone. So there is one common disorder, which is primary hyperaldosteronism, also known as CONN syndrome. So here you have an excess amount of aldosterone, and as the job of aldosterone is to retain sodium and along with sodium tag the water, so there will be hypertension and hyponatremia, and the patient will also have hypokalemia, because aldosterone helps to secrete potassium from the distal tubule, and metabolic alkalosis, because you will lose a lot of hydrogen from the distal tubule also. And most common cause of primary hyperaldosteronism is adrenal adenoma, and maybe in some cases adrenal hyperplasia or carcinoma may be responsible, but the most common is adenoma itself. And if you do some labs, you will have high aldosterone level, and this high aldosterone level will have a negative feedback on the JG cells, telling it not to secrete a lot of renin. So there will be less amount of renin. And secondary hyperaldosteronism is a condition where you don't have any problem with the adrenal gland, rather you have a problem with your blood volume system. So maybe due to some reason you have a decreased amount of blood supply to the kidney. So if kidney receives a less blood due to some reason, like someone has a renal artery stenosis, or someone has a heart failure or CLD, now the kidney sense that it needs to preserve some volume. So that's why it tells the zona glomerulosa to release a lot of aldosterone by releasing renin. So the zona glomerulosa cell increases the secretion of renin. Renin increases the synthesis of angiotensin 1 and then 2, and the angiotensin 2 actually causes the secretion of high level of aldosterone from the zona glomerulosa. So in case of secondary hyperaldosteronism, First, primarily you have a high renin, and this high renin ultimately will result in high aldosterone. So this is all from me today. Thanks for watching my video, and wait for more.